Dear Chairperson, it is great honor for me that my presentation has been selected in the Best Case session in EBC 2020. My name is Yoshinobu Murasato from Kyushu Medical Center in Japan. My presentation title is IVUS-guided Salvage for Guideway crossing into Pseudo Lumen, complicating huge hematoma in acute myocardial infarction. The case is of a 61-year-old male with acute myocardial infarction in infraval. The patient felt severe chest pain 2 days before and recurrent chest operation has been continued. ECG showed ST elevation in 2, 3, and AVF, and emergent CAG was performed. His risk factor was dyslipidemia and smoking. And here you can see there is a total occlusion of distal RCA, and there is no collateral from LCA to LCA. Emergent PCI was initiated by a young operator. He failed to pass the Guidewire, and the tip injection showed huge thrombus in RCA. Thrombus aspiration did not work effectively. At that time, we cannot find the distal pathway of the RCA integrally, and there was no collateral from the LCA. He called to me, and I changed the guiding system from 6-point to 7-point system to use the IVUS guidance. After 1.5 meter balloon dilation, the site where the Guidewire crossed into the pseudo lumen with huge hematoma was identified by the IVUS. This site, Guidewire located the huge hematoma, and in this site, Guidewire entered into the true lumen here. So, true lumen was identified by IVUS and marked by the IVUS. A 3.5 meter balloon was dilated at the true lumen. CAG showed the extension of the hematoma in both PL and PD branch. A Guidewire advanced into the true lumen of the PD branch using a double lumen catheter. Here you can see Guidewire is advanced relatively lower side of the hematoma, and the tip injection shows the true lumen in the PD branch. And also IVUS showed the Guidewire advanced through the true lumen indicated by the asterisk, and the extended hematoma indicated by the cross. This is a PD branch. True lumen was here, and around the true lumen, the huge hematoma was observed. This is a PD, still PD branch. From the 8 o'clock, this is the bifurcated side. PL branch was entered into the bifurcated side. This is the distal RCA members side. Guidewire located in the true lumen, and the upper side is a huge hematoma. Guidewire still located in the true lumen. And upper side is a huge hematoma. And finally, hematoma is disappeared here. So the Guidewire located in all segments in the true lumen. After 3.5 meter drug-electric stent implantation in the true lumen, CAG still showed the total occlusion of a PL branch and a huge hematoma. Guidewire negotiation to PL branch was so tough due to difficulty of identification of the entry point of the PL branch. So we use the combination use of the IVUS and double lumen catheter slipstream technique, and stiff wire could be penetrated into the occluded proximal side branch under the IVUS guidance. Then we advance the double lumen catheter to the PL branch and finally obtain the main branch of the PL branch. This is the scheme of the slipstream technique. A double lumen catheter is advanced along the guide wire, which is a cross in the wire lumen of the IVUS. A tip of the double lumen catheter is fixed at the wire part of the IVUS. Selective guidewire negotiation with strong backup can be achieved under the IVUS guidance. Here you can see IVUS monitoring is feasible during the guidewire insertion into the occluded vessel. IVUS showed the guidewire location in the true lumen indicated by the asterisk and the huge hematoma indicated by cross in the PL branch. So a 3.5 mm cutting brown was dilated for making exit of the hematoma space, and finally TIM3 flow was restored. The distal RC bifurcation was treated with crash stenting using the Resolute 3.0 mm stent for the PL branch and crashed by the 3.5 mm balloon, and 2.75 mm archmaster stent was deployed in the PD branch, and the final kiss balloon inflation was performed. Final CAG showed complete revascularization of the occluded RCA, and IVUS also showed disappearance of the hematoma in the stent implanted site. Here you can see this is the carina site, and this is also carina site, and the distal member cell was fully covered by a drug stent, and the position is excellent. In summary, a failure of guidewire negotiation to the occluded vessel due to huge thrombus resulted in the large extension of hematoma in the distal RCA, which led to difficult guidewire advancement in the patient with acute myocardial infarction. IVUS-guided guidewire negotiation into the true lumen was succeeded, and finally complete revascularization could be achieved. Slipstream technique with combined use of IVUS and double lumen catheter is particularly useful in the case with the angiographically invisible branching point in the occluded bifurcation region. Thank you for your attention.